Welcome to the Sunday special on TopMedTalk. It's a potpourri of our favourite longer pieces, ideal for downloading and enjoying when you have a little bit more time. TopMedTalk.
All right, welcome. We are at the 7th Annual World Patient Safety Summit in Huntington Beach, Southern California. This is TopMedTalk, and I am Desiree, Chappell, your host, and I'm here with my co-host, the editor-in-chief of TopMedTalk, Monty Mythen. Hello, Monty.
Hey, Desiree, great to be here.
It is great to be here. How are you doing?
I'm doing well.
Yeah,
doing very well.
We're getting warmed up here. We've had a couple great conversations so far.
Awesome conversations, and it's going to continue.
It is going to continue. We have the whole day. We look outside, it's bright and sunny, but we choose to be inside to bring the message to our TopMedTalk followers and everyone in the world. So anyway, we are so fortunate to have one of our dear friends on TopMedTalk and EdPom, Dr. Lee Fleisher. Lee, how are you doing today?
Fantastic. It's always a pleasure to be here with you.
It is. Thank you so much for sitting down with us. Well, we've had a little bit of time to catch up and offline, off of TopMedTalk, and some of the things that you're doing. We've been showing me some of your articles and some of the conversations that we've been having are just fantastic, and I want to share that with the world, everyone that we've been talking about. We talk a lot about brain health, and I know sometimes we that's what our conversation always migrates to. But today I kind of want to talk about some of the things that are in the pipeline, the things that you're doing and working on, especially kind of start with maybe the sociological aspect of care. I think that's pretty fascinating. But anyway, tell us a little bit about what you've been doing.
So a number of years ago, and I have to give a huge shout out to Justin Clapp. He is a medical linguistic anthropologist. Ooh. So he has a PhD in anthropology. And in fact, I think he is probably the only assistant professor.
You hang out with a different bunch to me.
I know, I love it.
Say that one more time.
Linguistic anthropologist.
Here we go. Beautiful.
So, and in fact, he is on assistant professor of anesthesiology. The funniest part about this is one of our colleagues, who is an anesthesiologist, had a daughter in the anthropology class at the University of Pennsylvania. And the chairman was going on about the fact that their children who were to the parents, that they will have a career because they have a graduate in the anesthesia department. But I think he's the only one.
That's fantastic.
But he has actually changed
a lot.
Had
some great conversations with him.
Yeah, so he's the only one that that I know of, but he's changed the way a lot of the work we're doing, and it actually came out of some of the testing and the questions that we started to ask about what is informed consent, what is shared decision making, and it came out of EdPom, sitting on the stage listening to. In the UK, it's mandatory to have shared decision making, and I started to say, does it really work? Does it exist?
Gosh, Lee.
I think you're gonna. I know you've had a publication out on it relatively. You're going to burst our bubble a bit, aren't you?
Well, the interesting thing about this concept and why an anthropologist is, we actually didn't accept the model. What we did is we interviewed people as to how they made decisions about going for surgery, and we started with. In the surgeon's office, embedded the anthropologist where he would watch the conversations and then interview the surgeon and the patient. And what's fascinating is that by the time they get to the surgeon, they sort of have already made up their mind. So when they sign that piece of paper that says yes, that's not real. That's a legalistic activity. But, they've already gone and talked to their relatives to say, should I get this hernia fixed? What treatment should I get? They then go and talk to their GP, as you would say, or their internist, and then they get referred to the surgeon. So by that time, they've already had preconceived notions. So it's actually, as we start looking at it, it's a social process that by the time you do the shared decision-making, there's not much of a decision left.
And it doesn't. It never changes.
It does, and it depends. I mean, those of us around the table, most of the people who were listening, anyone who has a sophistication, yes. But we actually started asking. Now I know this is going to burst another bubble.
I love you, Lee.
Does patient autonomy exist? Is that what's really important? because we moved away from this paternalistic, God forbid we should tell the patient what they should do.
Yeah.
Yeah.
But don't most patients want to know what we think?
Yeah.
Your expertise.
Yeah.
But I thought the shared decision making was, I think you should have a hernia repair, and I think you should have it done this way, and here's the risks and benefits. And you say, can you run that risk by me again? No one mentioned that word before. Or you think that...
So I agree with that.
Okay.
And we've had the pleasure of actually having lunch with a guy named Daniel Kahneman, who wrote this wonderful book, Thinking Fast, Thinking Slow.
Yeah.
He won the Nobel for creating behavioral economics. And we've said to him, how could we get past this idea of really having a shared decision? He said, the heuristics, the power dynamic is so great that you're never really, that frequently the patient is looking, most patients, now there are very sophisticated patients, but most patients are looking for the physician to give advice. There was a woman named Jessie Grumman, who was a psychologist who had 4 primaries and passed away, and she's written. And I heard her say when she goes to the doctor, another one that she's... What she wants is the same as when she goes to the car mechanic.
Oh, no, we've got a story about that from 2 weeks ago with Desiree.
Yeah.
Which we'll come back to in a
Yeah,
second.
go ahead.
She wants to go and say to the mechanic, what are the options? Give me option A, give me option B, give me option C. And she wants to authorize the car mechanic to fix the car. That's what her version of sort of shared decision-making, and she's a very sophisticated, she passed away.
Yeah, well, I wanted that too whenever I went to go get my car fixed, but I went to 2 different places and they told me 2 different things and laid out the options, and I still don't know who
to trust.
Who to trust. And it's like, I don't know anything about cars. I just want you to lay out, show me everything that I need to know about this to make my decision. I know, I'm sorry. My hands are going wild if you can't see me. But.
It's a really interesting thing. So we believe that decision-making is a social process.
Yeah.
So the question is, what if somebody had cardiac surgery and they're not doing well? And we're actually doing this research. Yeah. And their only life-saving thing they can do is to put them on ECMO to maybe salvage them. And the chances are really small. And we started studying this also, and we hope to write this up, but we have submitted some of this work, that the regret of the patient's family, because the patient usually is not in any shape,
right,
and the regret of the providers of not saying we can do everything for you is so great that no matter what, what risk we tell them, they have a 55% chance of dying and a 99% chance of being harmed. But is there that 1% chance that my relative will do better? This, I think, Monty, in the UK,
yeah,
I hate to say it, but you put limits.
No.
No? There are no?
No. There are emotional, social limits, and we might place them in a slightly different place culturally, but there are no you can't go for the 1%. If you are determined and your loved ones and everyone agrees it's in your best interest, we'll give you the fraction of a percent. But we might, culturally, there's a bit of a tendency to be more of the, I'm not sure that's what mum or pop would have wanted, and they wouldn't want this and that and the other, and perhaps the war babies, perhaps a hint of a waste of money creeps into their thinking as well.
It's a very interesting question. In a sophisticated audience, we really want to do shared decision-making.
Yeah.
And the question is, when do we have to start it? Mm-hmm. In a less sophisticated, do they really make their own decision? Because what's the chances that when you present the risk, you don't present your biases with it?
Well, that is the hard bit, is the independent broker.
Yep.
That's the skill that what I've been attracted to is Desiree wants to know what to do with her car, your friend did, is where's the independent equivalent of a financial advisor who is very skilled in bringing zero bias to the table. That's what we're seeking, I think.
So we've been trying to design the study, but the question is, back pain is a classic example.
Yeah.
And actually Danny talks about that. And if we went to 10 people and asked them would they get surgery, and they tell us 6 would, 4 would not. And there's actually an interesting work being done right now in some research studies to say, would you consent to be randomized to physical therapy versus back surgery? Yeah. If you get 9 providers to say one way, they won't be randomized. If the expert panel says it's 50-50, then they might be randomized. So, we're trying to think through, can we ever, it's been 30 years that we're talking about shared decision-making. And
could the computers help with an avatar of some form? Isn't there Carol being involved in a little bit of work to do
Carol's
that?
Doing some of that, isn't she?
Like take our biases out and just have the computer
AI.
Unemotionally turn around and say, I've looked at the algorithms and your chances are...
But it doesn't have to... you don't have to present that like that. I mean, you can present it
then the
way.
emotional pace could turn around and say that's going on in the background, but they're saying, have you thought about the fact that actually on balance you're probably not going to be helped by this knee replacement? You're more likely to have more pain than you are to have improvement. You could have improvement, but you're more likely to have...
So it's very interesting. There's a woman named Gretchen Schwarzy at, I think she's at Wisconsin, but she actually talks about we shouldn't tell people probabilities of bad outcomes. Okay, we should give them best case, worst case scenarios. Because if all you do is say your chance of dying and this and that is X, but if we say, and use stories, which is, we're here about stories. Yeah. Your loved one, or you, have a chance of getting walking again.
Yes.
And all this positive. But if the chances of walking again and playing tennis are lower, the best case, worst case may be better. Yeah. It's going to be... The bottom line is we're starting to ask the question that we've made all these assumptions. Mm-hmm. It's time to actually use the anthropologist to say, is this really what's happening when you're in the room? We don't know the answer. We're just studying it.
Yeah.
I'm going to let you wrap in a second, Desiree, but there are some recent papers that are out on this from your group. Where do we find them, Lee?
So we have the Annals of Surgery has our major paper. We have an editorial in, I think it's Anesthesia. Yep. And we also have one in the Joint Commission Journal.
We'll get all those in the show notes so people can look them up afterwards. It would be great.
Yeah, that's great. Well, Lee, as usual, it's always a pleasure to sit down and chat with you. Was there anything else that you had thought about that you wanted to mention on TopMedTalk today?
No, I think that's the real question, and this gets into how do we as providers act, is what's in our head, and that may be for a future discussion.
It's kind of scary.
How do we think, and what's even scarier is how does the next generation think?
Oh, yeah.
Oh, my God.
The millennials, because...
If you work it out, let me know.
If you work it out, let me
We don't know how to fix it. We're beginning to understand it.
Well, it's a step in the right direction for sure. But anyway, Lee, thank you so much again for sitting down with us on TopMedTalk. Hopefully we'll be catching up with you soon. We're going to catch you at... EdPom or SPAC? Are you going to SPACy?
Yes.
Oh, we'll see you at SPACy.
Actually, very good.
Yeah, that'd be great. So
and we'll be there recording. So
we are. Yeah.
Excellent.
Stuff in the pipeline.
And maybe we can get PJ Devereaux.
That's exactly. I'd already looked at it. Yes.
And he and I are supposed to have a discussion, not a debate.
Yes.
Of our philosophic approach.
Yeah, I love it.
We all want to understand. We're keen to know. We're not pro, and we just want to understand.
Yeah. Right. Why we took different philosophic approaches.
Yeah. Cool. Love it. All right. It's a date.
Very good.
Lee, thank you so much.
Lot,
Cheers.
Bye. Thanks for downloading and listening to TopMedTalk. TopMedTalk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the TopMedTalk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website edpom.org/meetings. Our next big event is EdPom USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. edpom.org/meetings.